Hello, Professor Hill and dear classmates. My name is Adam Chaudhry, and today I'm going to be presenting a musculoskeletal case I saw recently in clinic. This is a new patient encounter, and all identifiers have been changed for privacy. This patient is JM, a 42-year-old male who presents with knee pain. His chief complaint was, I've been having right knee pain for the past couple of weeks. His history of present illness. JM is a 42-year-old male who presents with right knee pain that started about 2 weeks ago. He reports the onset was gradual and not related to any specific injury or trauma. He states that around the time of his symptoms started, he had increased his physical activity, specifically jogging on concrete surfaces, about 3 to 4 times per week. He denies any falls, twisting injuries, or direct blows to the knee. He describes the pain as dull, achy, with occasional sharp pain, primarily located in the anterior and medial aspects of the right knee. On a pain scale, he rates it around 6 out of 10 at its worst. The pain is worsened by going upstairs, squatting, prolonged walking, and after activity. It improves with rest and is partially relieved by over-the-counter ibuprofen. He also reports mild morning stiffness, but it lasts less than 15 minutes and resolves once he gets moving. He denies locking, catching, knee instability, swelling, redness, warmth, numbness, tingling, fever, or chills. He also denies any history of prior knee surgery. So, pertinent past history. His past medical history is significant for hypertension, which is well controlled with medication. His BMI places him in the obese class 1 range, which is relevant given his knee symptoms. He has no known drug allergies. And currently his medication list shows as lisinopril 10 milligrams daily and ibuprofen 400 milligrams as needed for pain. And then regarding his social history, he works a sedentary office job, does not smoke, denies illicit drug use, and drinks alcohol socially. He reports exercising regularly and was motivated to stay active. So here's a review of symptoms that are pertinent. So it's a focused review of symptoms. So we're going to start off with musculoskeletal. Positive for right knee pain and stiffness. Constitutional, denies fevers, chills, or weight changes. A neurologic, denies weakness, numbness, or tingling. And for skin, no redness or skin changes noted. All other symptoms were reviewed and were negative. And then upon physical exam. On exam, the patient appeared well and in no acute distress. Focusing on the right knee. Inspection, no visible swelling, arrhythmia, bruising, or deformity. Upon palpation, tenderness along the medial joint line and patellofemoral region, no warmth or effusion, range of motion, full but pain noted with flexion beyond about 110 degrees. Crepitus was present with active flexion and extension. Special tests: anterior drawer, posterior drawer, McMurray, and varus/valgus stress tests were all negative. His gait was slightly antalgic, favoring the right side. assessments and differential diagnosis. So, based on the history and physical exam, my differential diagnosis included patellofemoral pain syndrome. So, my primary diagnosis given anterior knee pain, overuse, pain with stairs, and absence of instability. So, that's number one. Number two, early knee osteoarthritis, considering age, BMI, crepitus, and medial joint line tenderness. Number three, medial meniscal irritation, though less likely due to lack of locking or catching. And then number four, the pes and serin bursitis, considered but less consistent with pain location. So following for a plan, the plan focused on conservative management, which aligns with current guidelines. This included active modification with temporary reduction of high impact exercise, continue use of NSAIDs as needed for pain, ice application after activity, referral to physical therapy for quadriceps, hip, and core strengthening, education on weight management, and proper footwear. We discussed that if symptoms do not improve after 4 to 6 weeks or worsen, imaging such as knee x-ray would be considered. Overall, this presentation was most consistent with patellofemoral pain syndrome, and conservative management was appropriate at this time. Current evidence supports conservative management for patellofemoral pain syndrome. Management strategies include active modifications, and physical therapy are supported by recent clinical guidelines and systemic reviews published within the last 5 years. So for references, this includes best practice recommendations from the British Journal of Sports Medicine and the American College of Rheumatology. So I will be adding the 2 references to the bottom of this video for reference. Thank you, class, and thank you, Professor Hill, for taking the time to listen to my musculoskeletal SOAP note case study. Thank you, and have a great day.